research and training in parasite epidemiology and control based at McGill University. Before beginning, there are two important tools that you may find useful. First, translation is provided in Spanish and French, so you can find the interpretation tab at the bottom right of your screen and select the language of your choice. Second, if you have questions for any of the speakers, please type your question into the chat. And depending on time, I will be able to have them answered during the webinar. Should we not get to your question, keep in mind that the policy brief that we'll be talking about today contains most of the answers to your questions, or you could consult other WHO websites. So let's begin. Welcome to the launch of the WHO policy brief aimed at answering the question, are we doing enough to protect adolescent girls and women of reproductive age from the harm caused by worm infections? The worms we are talking about today are the soil-transmitted helminths and the schistosomes. These parasites are endemic in about 100 countries around the world, and about more than 1 billion people are affected by these infections. Moderate and heavy intensity infections can be a cause of important morbidity, especially in children and women of reproductive age. For this reason, in 2001, the World Health Assembly and all the member states endorsed a resolution aimed at providing deworming coverage to at least 75% of women and children. Initially, children were the focus of global events to implement large-scale deworming programs, and these programs have been quite successful. Over recent years, there has been increasing demand for guidance on deworming programs for adolescent girls and women of reproductive age. Several advisory groups have made important contributions, and today, as one of the highlights of World NTD Day, which was celebrated on Sunday, WHO is launching a policy brief aimed at providing comprehensive information on deworming programs for adolescent girls and women of reproductive age. This is the agenda. To start us off, we will have Dr. Antonio Montresor and Dr. Amadou Garba from WHO, who will expand on the rationale for this policy brief. They will be followed by 2 scientific presentations and 3 country examples of countries which are implementing deworming for adolescent girls and women of reproductive age. There will be 2 short videos and brief statements from key partner organizations. So let's begin with Dr. Montresor. Dr. Montresor is the focal point for intestinal parasites at the World Health Organization in their Department of Neglected Tropical Diseases. After obtaining his medical degree, he worked at a district hospital in Tanzania. And in 1994, he was recruited by WHO to its then Department of Communicable Diseases based in Geneva. In 2004, he was assigned as a public health specialist to the WHO office in Vietnam. He returned after spending 5 years in Vietnam and has been at the Department of Neglected Tropical Diseases since 2009. Dr. Montresor, the floor is yours.
Thank you, Teresa. Thank you very much. Yes, I have a few points to stress on the launching of this policy paper. You know that WHO identified 3 groups at risk for soil-transmitted helminth. There are preschool children, school-age children, and women of reproductive age. So the worming for children is going quite well. In 2020, we dewormed approximately 400 million children, and despite the complication generated by COVID pandemic. Unfortunately, the coverage of women is much less. And the aim of this document is exactly to provide a minimum strategy for endemic country to scale up this coverage. The strategy proposed is very simple: to utilize every occasion of the contact with the health services or other point of distribution with the woman and girl to provide the warning. Also, the strategy is expected to be very beneficial, and you will see the impact where we have been in the area where have been applied. And also, it's very feasible. We have today 3 countries who will show how they implemented, and you will see their the result. Thank you very much. Thank you, Teresa. Back to you.
Thank you, Antonio. I would now like to introduce Dr. Amadou Garba from WHO. Dr. Garba is with WHO's Department of Neglected Tropical Diseases, again based in Geneva, Switzerland. He leads the global program for the elimination of schistosomiasis, and as such, he works very closely with colleagues who are involved in the control, prevention, and elimination of soil-transmitted helminthiasis. Amadou works with an array of partners and also liaises with colleagues at Merck, the company that donates up to 250 million tablets of praziquantel annually. Dr. Garba, the floor is yours.
Thank you, Teresa, and dear participants. To add to what Antonio said, schistosomiasis and soil-transmitted helminths affect billions of people worldwide. And they have, I would say, the same favoring factors, which are the lack of accurate sanitation, the lack of clean water, and also human behavior because of their activities that put them in contact with the transmission sites. For schisto, globally, 241 million people at least required treatment yearly. And among them, we have 56 million women that are affected by the female form of schisto, which we call female genital schistosomiasis, which can manifest as genital bleeding or bleeding during intercourse. It can also manifest as discharge or cause ectopic pregnancies or infertility in women. The first evidence-based WHO guidelines for schisto and also for STH recommended the treatment of all at-risk groups that are affected by the disease. And women of reproductive age is one of the at-risk groups to be targeted. And it includes pregnant women from first trimester of pregnancy. It also includes adolescent girl. It includes lactating women. What we know is that the medicine used are effective in reducing the morbidity due to the disease. They reduce the worm burden, and from this reduction of the worm burden also, we have reduction of the morbidity that the disease caused in infected people. So treating women of reproductive age should be something that can use either preventive chemotherapy or the existing infrastructure that already exists. I mean, the prenatal care services, the occasion of screening of cervical cancer, HPV, or activities, or vaccination services. This is important if we really need to reduce the morbidity and reach the objectives of UN goals that have been set for 2030. So this is in summary what I would like to say as rationale for the development of this policy paper. Thank you, Teresa.
Thank you very much, Amadou, and Antonio and Amadou, thank you for giving us the basis and a little expansion of the rationale for this policy brief. I would now like to introduce our first speaker. Her name is Dr. Bhavna Walia. Dr. Walia is an assistant professor of public health at Syracuse University in New York. In her research, Dr. Walia applies econometric techniques like causal inference and cost-benefit analysis to examine research questions in health policy, specifically as it relates to maternal and child health and healthcare efficiency. Her research has been published in leading journals such as the BMJ Global Health, Plus NTDs, Social Indicators Research, and JAMA Network Open, among others. Dr. Walia, the floor is yours.
Thank you, Teresa.
Perhaps I will also indicate the title of your talk, which is Impact of Deworming on Neonatal Mortality and Low Birth Weight. Thank you.
Thank you. Hello, everyone. Thank you. This has been a great experience collaborating with most of the stakeholders across the globe on this very important issue. So as Teresa mentioned, so our research article called Routine Deworming During the Antenatal Care Decreases the Risk of Neonatal Mortality and Low Birth Weight in the cohort of countries that we've looked at using survey data. So this research, the main motivation is, we're trying to, piece by piece, working towards a world which is safer for, mothers and their newborns. And the soil transmitted helminths, are very common infection among pregnant women in areas with poor access to sanitation. And the importance of, proper sanitation is quite well established in the, in the scientific research literature. So specifically for this article, we really focus on the deworming medication, which, is very cheap, it's safe. And so what we add on is the health benefits of deworming during the pregnancy to, further this research. So development economists have in past, found all the positive impacts of deworming. And they've found very significant effects. And the two main reasons for the economic significance are the positive externalities that programs with mass deworming creates. So you have, just like mass vaccinations, when somebody or a community or a country, the members of the country are dewormed, it not only helps the people who are getting dewormed, but also the people around them. So from an economics perspective, that creates a very large positive externality. And also the rate of return on this intervention is very high, given the cost of the pill and given the, the kind of somewhat easy application, just take the pill and then you get the benefits. So the treatment is very cheap and it has many proven health and labor market benefits. That's what some of the previous research has shown, that you can see the effects of deworming later in labor market, and you can see the effects of deworming in the number of school days that children miss, and then eventually their skill sets into labor market. For this specific paper, what we look at is our main outcome variables that we look at is neonatal mortality, which is our primary outcome variable, and also a secondary outcome variable, which is low birth weight. To analyze, we get, we created a retrospective cohort of more than 800,000 births and from about 95 demographic and 95 countries, and using the demographic and health survey data sets to estimate the impact of deworming during the routine antenatal care. So there's no really extra, again, when I talk about the rate of return, that there is already this very well established network of antenatal care, and you can just during that time, you can provide this dose of, the deworming pill. And what we find, for the analysis, we've used different statistical, programs and softwares. But what we really did was we first matched the births on the probability of receiving the deworming during the ANC. What is the probability of actually the mothers, when they're going for ANC, they actually get the deworming pill. And then we modeled birth outcomes with the matched group as a random intercept to basically estimate the effect of deworming during the antenatal care after, obviously accounting for different risk factors for different mothers in different countries and different regions. So we also tested for the effect of modification of, the soil transmitted helminth prevalence on the impact of deworming, because there are some countries which have, low prevalence, there are other countries which have high. So how does that, while estimating the impact, how does that change? So again, our two main outcome variables, again, the primary one is the natal mortality, and then a secondary one is of low birth weight. So here's the kind of the main result where our dependent variable with the variable we're looking at is neonatal mortality, and the results, the background, as you can see, we've controlled for a lot of confounding variables that could possibly have an impact, and quite a few of them, such as your mother's age, mother's parity, household location. These things are important, but the main result, which was I think the most important thing coming out of this research, was the main result was this 14% reduction in neonatal mortality. As you can see, I've kind of pulled it out and put it on top of this table right here. As you can see, this 0.86 reference. So this is what was the outcome of deworming, controlling for a lot of socioeconomic, controlling for a lot of things that the data set, the secondary data set was able to provide us, controlling for all that. This is the impact that we see, which is as an econometrician, which is this is really very strong, and this is something that can really improve the lives of the pregnant women across the countries that we looked at. So we have so the receipt of deworming medication during ANC was associated with a 14% reduction in the risk of neonatal mortality. And there are some of the stats, the sample size, and we really did not see much difference in this reduction between high and low transmission countries. So that also tells us that a global kind of effort towards this to help to protect pregnant mothers and the women of reproductive age and their newborns. This is pretty big. And then we also looked at low birth weight. So again, these results, in low and high transmission countries, we found a range of positive results. Definitely has a positive impact on the odds of low birth weight, but there is some variations of that. Again, our primary focus for the research was neonatal mortality, and this was, we had this information in the data set, so we also estimated and found that there is a positive impact, not as large as the with neonatal mortality, but there is definitely a positive, significant impact on low birth weight of deworming medication. So, with this research, we provide empirical evidence as to the impact of deworming in pregnant women on neonatal health of their infants. And, the policies, again, just to stress again, the cost benefit, the rate of return on a policy, a global policy like this are economically very, very high. Thank you, everyone. Here is the the reference for the article, and I would like to thank all the collaborators. This was work done with everybody's effort, and I hope this can help make the pregnant women safer. Thank you.
Thank you so much, Dr. Walia. And I would encourage the audience, if they have questions about your presentation, to put them in the chat, and we will take a look at them and get them ready for the question period, which will follow the next presentation. So I'd like to introduce the joint speakers of the next presentation, which will be on an integrated approach to cervical cancer and female genital schistosomiasis disease control. So I would like to introduce Dr. Erin Chetland, who is a professor at the University of KwaZulu-Natal and director of its Bright Research Academy in KwaZulu-Natal. In Norway, she leads the Oslo University's Hospital Research Group in tropical, imported, infectious, and reproductive diseases, and is a clinician in infectious diseases. She has led research on schistosomiasis and HIV in South Africa, Zimbabwe, Madagascar, Kenya, and Malawi. In collaboration with WHO, she has produced the Small Pocket Atlas on female genital schistosomiasis. Together with Erin is her co-speaker and colleague, Dr. Teresa Norris. Dr. Norris is a sexual health specialist and HPV expert with over 17 years experience delivering positive, comprehensive sexual and reproductive health programs and championing disease prevention strategies. Teresa is the founder and president of HPV Global Action, a Canadian registered charity that focuses on bringing leaders together to communicate and provide solutions regarding worldwide HPV prevention and cervical cancer screening and treatment challenges. Erin and Teresa, welcome. The floor is yours.
Yeah. So today we'll be discussing an integrated approach for female genital schistosomiasis and cervical cancer. And as Teresa so kindly introduced us, we'll be covering an array of different issues to support the deworming strategy that we're launching today.
So in this presentation, we're going to be talking to you about female genital schistosomiasis, which may be the commonest gynecological lesion in your population. It's a differential diagnosis to cervical cancer and cervical dysplasia, and to chlamydia and herpes simplex virus. So it starts in childhood and it lasts. We don't know for how long. It's not diagnosed, and we're going to tell you a little bit about the way forward. This is a typical transmission site, a peaceful afternoon in Madagascar. And there are at least five types that affect the humans. Schistosoma hematobium is the one that affects genitals mostly, and it's been renamed by the WHO to be urogenital schistosomiasis, but all the other worms can also cause lesions in the genitals. And we think it's through blood vessel anastomosis that the eggs are dispersed to the other genital pelvic areas, like the genital tract and the intestinal tract. There are four main lesions: the grainy sandy patches, the homogeneous yellow sandy patches at 15 times the magnification, and these are the rubbery papules, which we only seen in Madagascar. They're like pimples. If you squeeze them, nothing comes out of them, but they're full of schisto eggs. And lastly, the abnormal blood vessels, which to any gynecologist will seem like this could be cancer. This is a severe case where you see contact bleeding. The speculum has swept across the surface, and I'm trying to wipe and see what's behind all this blood. And it's a bed of sandy patches that is causing this surface to be vulnerable. This is another lesion. It looks like cancer, but it is female genital schistosomiasis. This slide is key, really. It shows us that you have to treat early. So you see that the ones that were treated early had much less lesions than the ones who were treated late. However, it's still 20%, if you look at the axis, that still have lesions. We have a long way to go before this is prevented. There are implications of female genital schistosomiasis on HPV and HIV. We found an association between the higher risk HPV, which causes cancer, and the FGS lesions. But we don't really know whether FGS lesions produce more cancer. There is also an association between the VIA technique of finding cancer or precancers, which is used in most of Africa. So we call it visual inspection with acetic acid, and FGS. And there's lower HPV clearance. So the body usually wants to tidy up and remove the HPV that causes cancer, but FGS seems to stop that somehow so that the HPV remains longer. And then there's a higher HIV acquisition in women with schistosomiasis. You imagine the surface looks as terrible as it does, that you have less possibility of removing the HIV virus. And these ones, we don't know whether they cause more cancer.
So what we're looking at here is an overlapping actually of the continent of Africa, where we're seeing clearly in the first image the incidence of cervical cancer, and then in the below image, the prevalence of schistosomiasis. So we're seeing that there's an interesting overlapping here, which is why we're so interested in integrating an approach.
There are a lot of unresolved issues. For example, what are the implications of having stinking discharge or pain when you have sex? What are those implications on a marriage, for example? What are the implications on the HIV epidemic, on the prognosis of cervical cancer, or on detection of cervical cancer, the diagnosis itself? Currently, no women are diagnosed for FGS. No women are currently informed about that they have this disease. No women are treated. And FGS is not mentioned in any prevention program.
So clearly we need to do something about this. So what do we know about the problem of cervical cancer and female genital schistosomiasis in sub-Saharan Africa? Well, first, in 2018, 570,000 women were diagnosed with cervical cancer, and 90% of whom live in low and middle income countries. Secondly, in sub-Saharan Africa, it has the highest incidence of mortality of any region in the world, but has very few organized cervical cancer screening or HPV vaccination programs. And then thirdly, an estimated 56 million women may have female genital schistosomiasis in this region, but almost none are diagnosed or treated. So we see that there's some overlapping goals that the World Health Organization has set out for 2030. And firstly, in the sphere of cervical cancer elimination, we're looking to get 90% of our girls fully vaccinated with an HPV vaccine by the age of 15, and that 70% of the women screened with a high performance test, both at 35 and 45 years of age. And then thirdly, that 90% of women identified with cervical disease receive treatment, which will really mean 90% of these women will have their precancer treated, and 90% of them will have long-term care for their evasive cancer. And then we're also looking at the same 2030 goal to eliminate the transmission of schistosomiasis. And then we have an interesting opportunity through a deep learning tool called automated visual evaluation, otherwise referred to as AVE, that can be used as a screening method for both of these diseases. And what we're trying to do is determine the influence of female genital schistosomiasis on cervical cancer and the prognosis and the misdiagnosis. So we have a project implementation that we're looking at to, first of all, look at it for disease prevention that requires tailored, approaches in each country. Firstly, we need to be considering country-specific resources, needs, and attitudes to ensure that these projects will work. Thirdly, we need to be maximizing cost effectiveness with limited resources, which is why coupling these two diseases is such an interesting idea. And there's the role of non-governmental organizations in implementation. So first, it's to spearhead population-level engagement by connecting and empowering communities, academics, and professionals to promote HPV, cervical cancer, and female genital schistosomiasis awareness. It is also to build trust with local communities and identify needs by implementing inclusive, evidence-based educational programs to promote positive sexual and reproductive health outcomes. In addition, we want to be able to support, develop, and implement worldwide evidence-based initiatives to improve on three spheres, first being HPV and cervical cancer prevention, secondly, female genital schistosomiasis diagnosis and patient information, and thirdly, quality of treatment it has to be tailored to the needs through research and policy initiatives. And we also need to be acting to mediate discussions between key stakeholders that include politicians, pharmaceutical companies, researchers, community leaders, healthcare professionals, and other local non-governmental organizations. And then, of course, key is advocating for policy adoption and sustainability to ensure the success and long-term sustainability of these projects.
So we want to help eliminate schistosomiasis transmission by 2030. But FGS will be present likely 50 years after elimination. We want to optimize the implementation and integrate the two diseases together. So you have cervical cancer, FGS, and schisto control. Want to help families that are affected by both these two diseases.
So we've established two targets, the first one being simultaneous prevention for girls aged 9 to 14. And then the second target is simultaneous screening and treatment for women 25 to 45 years of age. So the first target, what we're looking at doing is combining HPV and female genital schistosomiasis prevention. So it'll first look like a countrywide HPV vaccination program run through Gavi, while simultaneously providing praziquantel through Gavi to supplement the mass drug administration programs. And then in our second target, that same overlapping would be to first of all be doing a screening for cervical cancer lesions using this deep learning tool that I referred to earlier, the automated visual evaluation, and then providing the treatment of cervical cancer lesions when detected, while simultaneously then screening for female genital schistosomiasis lesions using the same automated visual evaluations tool, and then providing praziquantel for female genital schistosomiasis cases and their families, which is key to reaching these hotspots. So we're seeing that there's potential benefits of these integrated programs. First being that many Gavi countries also have an objective of eliminating schistosomiasis transmission. So we're saving resources firstly. Secondly, partnering with countries in sub-Saharan Africa to bring efficient, comprehensive screening and treatment for cervical cancer and FGS is definitely the way to go. And we're increasing the probability of reaching these WHO 2030 targets for elimination of schistosomiasis transmission, while also meeting the WHO targets for cervical cancer elimination in the next decade. It also gives us an opportunity to be mapping for female genital schistosomiasis and cervical cancer via a pilot project, proofs of concept studies that both Erin and I, our groups, are looking at on the continent of Africa in several places. These initiatives in individual countries will be able to assess the acceptability and feasibility, and then move towards scaling it up for population control in many African countries. There is a critical role of non-governmental organizations like HPV Global Action because we act as a nexus for scientists and researchers and government and communities and global partners, which include the WHO and Gavi and industry, and the list just goes on and on.
So thank you.
Thank you very much. We couldn't be here without all of the support of all of the people that we work with in both of our spheres. And we're very excited to keep you abreast all of the improvements and successes of our collaboration together. Thank you.
Thank you so much, Erin and Teresa, for that integrated presentation. So now I'm going to open the floor for questions. I've asked Dr. Montresor to keep his eye on the chat so that we'll have some of your questions directly. Antonio, do you have a question right now?
Yes, Teresa. There is one question that is asking Dr. Walia, what are the route of administration and the dosing of the warming? So if you can briefly mention this.
So I think that a lot of deworming programs are very country specific. So for our project, you know, it would have been really nice to see the difference between 1 dose and 2 dose. But the more research I did, I found out that it's actually some countries it's just 1 dose, other countries it's just 2 dose. So we used a very rich secondary data set. But the challenges with secondary data set are that you have what you have. So in the demographic and health surveys, they only ask this question that did you get a dose? Yes and no. It's just a binary variable. It does not ask tell us anything about, you know, the number of doses. So we are, as a research group, I think kind of digging into more secondary data sets and figuring out, even for a limited set of countries, if we could find out, you know, the number of doses, and then if we could calculate the difference, I think that would be, really informative.
Thank you. There is another question, Teresa. This is for Aaron, and this is in Spanish, so I'm not sure I'm translating exactly, but basically is asking about the diagnostic, differential diagnosis between cancer and schistosomiasis.
So to the naked eye, the diseases look the same, and that's what most of us have. Also using the colposcope, so you need to go and do further investigations to differentiate. So we do a biopsy to differentiate between the two diseases. And pathology services, as you know, is not available, but you can, with the AVE tool, you could detect the color of the lesion and differentiate it that way.
Then there is a question from Teresa Norris that is asking if Gavi has sufficient resources to support this integration of the worming with HPV vaccination across sub-Saharan Africa, or if not, what are the steps that are planned?
I think that right now what we're doing is we're trying to work towards that, but to say that we're at a place right now where we could fully implement across the entire continent a combined strategy, I don't think that we're there yet, but I think that we need to start looking at the idea to see where we could go with this and take those opportunities where they do, where there is that option, depending on which country it is. I think that that'll be something that has to get looked at on a country per country basis to see also the level of female genital schistosomiasis in the country, which is also going to be a key determiner on whether or not this coupling of using Gavi vaccination programs is a good fit. But I think that we're going to have to be monitoring this in the long term to see what this idea will look like.
There is another question for Beverett, is regarding the restriction about the different trimester of pregnancy. If this is, what are the restrictions for the administration of the worming for soil-transmitted helminth?
I think that again, maybe Antonio, you can add to that. I'm not completely aware. Again, it's very country specific. So our research kind of just looked at like the impact of mass deworming, but what countries' restrictions are, like the country specific results, I don't have, but I have the results from this project. We have the results from like countries combined using the secondary data sets. Again, the trimester restrictions also vary. So for some countries, just from looking at the literature, from some countries, there are not any restrictions, from others there are. So we kind of just combine them, whether they were given a dose or not. So unfortunately, given the demographic and health survey, we don't have any information. I don't know if you know anything more about that, Antonio.
Yes, the recommendation of WHO is to deworm after the first trimester. So they exclude the first trimester of pregnancy. This is not because there is any demonstration of harm of the administration of drug on this trimester, but just to as a general recommendation for women not to be confused. No drug should be administered in the first trimester. So, but of course, every country have different approach on that.
I have a question for you, Dr. Walia, and that is, were you able to see any time trends in your analysis? Because the data sets that you were using spanned a number of years, I understand. And so are you seeing an increasing trend in deworming during antenatal care in the data sets that you used?
Yes. So yeah, we do see, but I won't really say. So I'm going to say the same thing again, but some countries, yes, others not. So it's, but overall, there is a positive effect. As I said, we're building up scientific literature to support this policy, and I think it is having an impact. And I think one of the big reasons, like there's reluctance, right? With the pregnant mothers, there is a lot of reluctance on, how is that going to affect the baby? But I think what I was, we as a research group, we were very excited is that, reducing neonatal mortality with that large of a margin was, was a very positive impact. But answering your question, Teresa, that overall, yes, but then again, I cannot say specifically for each country that is true.
Okay, but the trend is improving, so this is
Yes.
a positive sign. Yes, very good.
Yes.
Antonio, do you have any more questions for our
No.
speakers? I have a question for Dr. Chetland or Teresa Norris. Are HPV vaccination programs in STH endemic countries common? And what deworming coverage level would you expect to reach if deworming were piggybacked with HPV vaccination programs?
Teresa, do you want to answer
the first part
what the rollout is?
Right now, there's one thing we don't know exactly the full list of what Gavi countries are going to be rolling out vaccination. COVID has really put a glitch in what the original plans were. So I think that for right now, all intents and purposes, they haven't been completely clear about where we're heading towards in this year 2022. I know that we do have 2030 objectives that we want to make sure that the list of countries are starting. But of course, being that not all of these countries that are targeted have COVID situation under control, that will be pushing back some of those starting programs. I can't remember the second part of the question. Maybe Erin, you could take on that part for us.
Yeah, I think there's an enormous thrust in the cervical cancer community to push forward to control cervical cancer. And I think it's from the NTD community for us to be able to piggyback that as the little sister in the system on a disease that is life-threatening. And to me, the most dangerous situation would be that you are misdiagnosing something as cervical cancer when you think that it could be, when it is genital schistosomiasis, removing part of the cervix unnecessarily, creating problems for the women fertility-wise, and vice versa as well. Should you diagnose FGS and it is cancer, that would be a catastrophe. So the two diagnoses and the two management strategies need to be hand in hand. And the same goes for the young girls. We know that FGS can be prevented if you treat it early. So they don't have to walk into their first sexual intercourses with damaged genitals. We have, as the little sister in this scenario, with much less funding, much less push, we have an excellent opportunity to try to wedge our way in and join with the big sister in this program. So I think it's an opportunity for us.
I know in our community, I can definitely just back that by saying we're making so much headway of sharing this information within the cervical cancer sphere. To many of us, the learning about the prominence of female genital schistosomiasis is new for us. And then also further to that is adding that opportunity to have a deworming strategy coupled in a lot of our projects is something that's new in our community. And part of the reason of this webinar is to really share that new integrated approach so that we can really grow this relationship and then have more success in both of the targets moving forward.
Thank you very much. And I've been looking briefly at the chat. We have quite a number of questions. We can't get to them right now. We're going to have a short pause for a video. And then come to some country examples. But I do want to emphasize that we will keep all the questions in the chat, and perhaps in the second question and answer period, or perhaps at the end, we will have some extra time. But don't worry, your questions will be recorded and we will certainly take a look at them in due time. So thank you very much for that. And now we will pause to have our first video, which is entitled Benefits of Deworming, Impact on Human Development, WHO Recommendations and Safety. So if we could cue the video. Thank you. That was a very nice interlude and a very nice introduction to our next section of the webinar, which will be to have 3 country examples looking at deworming for soil transmitted helminthiasis and schistosomiasis. So I would like to introduce our first speaker. It is Dr. Virak Q from Cambodia. Dr. Q is the manager of the National Helminth Control Program, Ministry of Health in Cambodia. His interests include research and control of neglected tropical helminthiasis, including STH, strongyloidiasis, schistosomiasis, taneiasis, and foodborne dermatodiasis. He has published in many journals, including Lancet, Emerging Infectious Diseases, BMC Medicine, Advances in Parasitology, etc. Dr. Virak Q, the floor is yours. And the title of your, I think you will just present the Cambodian experience with respect to deworming in women of reproductive age. Thank you.
Yeah, thank you very much, Teresa, for the introduction.
Yes, if you could put your screen onto presentation mode, that would be terrific.
Okay, sorry. It's on the presentation mode.
It's not there yet,
Sorry.
Virak.
Sorry.
That's all right. We have lost your screen.
Oh, I'm sorry. So,
no, it's okay. You can go.
That's okay.
You can
All
see
right.
how much.
Okay, that's fine. If you go back to your first slide, if you need to, go ahead.
Okay, so yeah, so good. Thank you. And sorry for the problem. So good morning, good afternoon, and good evening to everyone. So today I have a very good honor to share with you the experience of the Cambodia in the deworming of the women of the reproductive age. So let me start with some key milestones of Cambodia. Actually, for those who doesn't know where is Cambodia, Cambodia is a country located in Southeast Asia, bordering with Vietnam, Laos, and Thailand. And there are many neglected tropical helminthiasis, including schistosomiasis, soil transmitted helminths, lymphatic filariasis. It's endemic in Cambodia. And after a few decades of the civil war, in 1997, the Ministry of Health has officially established a national helminth control program for the control integrated with the STH, schistosomiasis, and lymphatic filariasis. And several years later, the National Task Force policies and the guidelines for the helminth control has been developed. And I just wanted to emphasize that the members of the National Task Force include the representative from different programs or departments of Ministry of Health, but also from the representative from the Ministry of Education, Ministry of the Rural Development, Ministry of the Agriculture, and other NGO and UN agencies such as the WHO and UNICEF. And the STH MDA has been started since 2005. We're using the mebendazole or albendazole we provide twice a year to our target population, such as school-age children, and women of reproductive age at school and also in the community through the outreach activity. And since the beginning of our MDA program, besides the Ministry of Education, who was helping us in deworming the school-age children in the public primary school, we had also integrated with existing programs in the Ministry of Health, such as the API program, the vitamin A distribution program, the iron supplementation program, which is working on, we call here the family planning. They're working with the women, and also with the malaria program during the distributions of the insecticide treated net. And to reach the integration, the idea of this integration is to reach the remote community where we are missing in the school or in the health facility. And just to emphasize that the SDH activities, for example, the distribution of the tablet and the reporting system, the reporting the MDA was the responsibility or doing by the health centers. And you see here, this is the online MDA reporting form, which is reported by the health center through the health management information system at the national level. So once the health center report at the health center, the data is online. It's sent to our national level. So you can see here the reporting of the women of reproductive age. For example, here the first, the second and third trimester of the pregnant women, but also the postpartum mother also in the report, which means that they are our target population. They receive the drug and they will report the deworming count. Now, after 10 years of deworming, we have revised our guideline, and we this time expand our target population. For example, for school children, we are not just doing in public, but also we expand to the private school. And this time, not just primary school or kindergarten school, but also the secondary and high school. So to reach to cover we expand this target population. But also here for the women of reproductive age, we also expand our target. I mean, to increase the MDA coverage by this time, not just using all the existing outreach activity which is doing by the health center, but also where we expand to the women who are working at the garment factory or enterprises or plantation, which is under another ministry of another ministry. We call the Ministry of Labor and Agricultural Training. So this we have expanded the target to the increase the MDA coverage, and also not just that, we also revise the online reporting form. And this time you see it's the same, the health center will do it and they will report it. And here you see that women or adolescents, girls and women are in the reporting online report MDA reporting form. So what did we learn from our almost 20 years of the SDH deworming program? Actually,
yes, in 1 minute, yes, in 1 minute, Dr. Kyo.
Yeah, this is the after 20 years to see that the lesson that we learned is that integration different diseases in the same. For example, here schistosomiasis, lymphatic filariasis, and SDH, but also integration with other programs in the ministry and also with other ministry, for example, Ministry of Education or Ministry of Labor, who are working on different target population. So this is what I can share with you. And sorry for the time.
Thank you so much. Thank you so much. I know that the audio was a little difficult for some people to hear, but I think we got the main message, and we can elaborate a little bit more during the question and answer period. Thank you. Thank you so much. I would like to introduce our next country representative. He is Dr. Martin Casapia. Martin, if you would queue up your presentation, please. Dr. Casapia is a professor of infectious diseases in the School of Medicine at the Universidad Nacional de la Amazonia in Loreto, Peru, and he is an attending physician in the Hospital Regional in Iquitos. He's the principal investigator and director of an NGO called the Asociación Civil Selva Amazonica. He has over 20 years of experience, including clinical trials, focusing on helminth infection, malnutrition in children, malaria, and HIV. Dr. Casapia, the floor is yours. Dr. Casapia, are you there? Could you unmute your microphone? Thank you.
Thank you, Teresa. Thank you for the invitation. And today I want to share our experience in the warming of reproductive age in Peru. We have a tropical medicine center in Iquitos, which is the main city in the jungle of Peru, where we have been working on research for almost 20 years. Our institution has developed capacity to conduct clinical trials and other studies related to infection disease and tropical medicine. We have a qualified staff with long experience in research, and they also have training in diagnosis, treatment, and prevention on tropical disease, focusing on STIs, dengue, malaria, HIV/AIDS, and COVID-19. We are proud to have a long-term collaboration with McGill University Dr. Yorgos, with whom have worked for over 18 years, and we have also implemented and conducted different kinds of study design like case control, cross-sectional cohort, and several randomized double-blind placebo-controlled clinical trials. Additionally, we have performed community interventions. Our study have included pre-scholar age children, scholar children, pregnant women, and the community. We have always looked to find helpful evidence to allow decision-making in public health and establish policies. These relationships have also been scientifically productive, with many manuscripts published in important journals where master and doctoral candidates of McGill University have participated. Our research has been developed in all stages of life. In pregnancy, the randomized clinical trials, the intensity of STIs and anemia in pregnant women using mebendazole. During delivery, maternal deworming research study called MADRES. In this study, pregnant women took albendazole immediately after delivery. Additionally, we worked on base school intervention with a massive deworming program through teachers and students in school-age children. In this graphic, we can see the result of the survey performed in the whole country. They found that the prevalence of anemia among WRA is high, reaching almost 21%. This value has been kept steady during the last 5 years, from 2015 to 2017. Moreover, among pregnant women, the prevalence was higher at 25%. Consequently, we can make some important observations. Anemia in WRA is a public health problem in Peru. Anemia prevalence is highest in pregnant women. Subnational data are needed to identify high prevalence areas. And the last intervention are needed to reduce anemia, especially in pregnant women. This table shows a survey made by René Laroque among more than 1,000 pregnant women in Iquitos in 2005. By that time, it was found that 90% of them had any STH infection and almost 50% anemia. We can also see in the results that STH have individually prevalence very close to 50% of highest. In general, we can say Peru has had an extensive scientific production related to the warming with more than 30 published papers. Our team working with McGill University contributed with many of them, always giving valuable information and evidence for decision makers. Our finding established a strong link between anemia and worm infection among WRA, which was informed to authorities and the government of Peru for taking into account the Peruvian health policies. Later, this information was used in the official guideline.
You are going to resize, thank you.
So in December of 2013, Ministry of Health launched the official guideline for integral maternal health care, where it was recommended starting at 35 weeks of gestation, deworming for endemic areas like Iquitos, for example, where we have performed our research.
You have 1 minute left, Martin.
Yes. In 2017, the Ministry of Health launched another guideline for the large-scale deworming program in Peru. People higher than 2 years old were considered in the program, which include families and pregnant women starting in the second trimester. Then the deworming program in Peru reached girls in primary school and secondary school, additionally pregnant women during antenatal attention. We have the main challenge in COVID-19 pandemic, with collapsed our health service during 2020 and 2021, and the deworming program has not worked accordingly. Nevertheless, in 2017 was launched the National Deworming Day, twice a year, in the third Sunday in March and September. On the other hand, we have some opportunities like PGBAC on the other community-based program, including programs supported by 5 basic organizations. Taking into account, the school has been closed for 2 years. Thank you so much.
Thank you very much, Martin, for giving the Peru situation. We'll continue now on to Sierra Leone with Dr. Mary Hodges. If you would cue your presentation, Mary. Dr. Hodges joined Helen Keller International as country director in 2008 and supported Sierra Leone's national NTD program scale-up of mass drug administration for the elimination of onchocerciasis and lymphatic filariasis and the control of STH and schistosomiasis. After recently leaving this position, Mary was appointed as an adjunct professor at Njala University in Sierra Leone. She is a British pediatrician with 40 years experience in Africa in child health, nutrition, neglected tropical diseases, and health system strengthening. Mary, the floor is yours.
Very much. I'm going to present on the various studies, interventions, and lessons learned from Sierra Leone over the last 4 decades. Next slide, please. Sierra Leone is a small country, but we're growing at a rate of about 2% per annum. And we have a classical health structure from community level through peripheral health units to district level. And we have been consistently ranked amongst the least developed countries in the world according to the Health Development Index. Next slide. The most important thing to know about Sierra Leone is the civil war. Sierra Leone went through 10 years of war, ending in 2002, which left the country infrastructure and its human resources severely degraded. Since then, investments have focused on decentralization, capacity building in the health sector, maternal and child health, and neglected tropical diseases, as shown in the slide. Next slide, please. Despite all of that, we remain with some of the highest maternal, neonatal, infant, and child mortality rates in the world. However, we have made significant progress in the realm of neglected tropical diseases, both schisto, STH, LF, and onco. There is still a lot of work to be done in terms of access to modern contraception across all women of reproductive age, and also the quality of care offered during antenatal clinics. Next slide, please. This slide is very busy, but I'll just take you through the important points. Post-war, one of the first programs to get re-established was the National Onchocerciasis Control Program, which targeted meso and hyperendemic villages, but quickly evolved into a nationwide lymphatic filariasis elimination program funded by USAID. By 2017, the LF program had begun to achieve its elimination targets and started transitioning back into an onco program, but this time an onco elimination program, not an onco control program, targeting everyone over the age of 5 in all but 2 districts which are non-endemic for onchocerciasis. Fortunately, we've been able to piggyback MDA for soil-transmitted helminths into this onco platform, but for school-age children only. In addition, Mother and Child Health Week started in 2006, twice a year, targeting albendazole at preschoolers 1 to 4 years of age. And we have made a very successful transition from mass campaigns over the recent 4 years to routine service delivery in peripheral health units by combining deworming with improved access to family planning. So all mothers nationwide should be able to go to a health facility for vitamin A and albendazole for their preschool age children and leave having been effectively counseled on appropriate modern contraception and been offered the option for long-term hormonal implants by a trained health worker. Next slide, please. So this is the result of the last survey performed in 2016, which shows that we have reduced overall prevalence to less than 20% for soil-transmitted helminths, with moderate and heavy intensity infections to less than 1%. This has to be compared not so much with the baseline that was done for USAID in 2008, but looking at it from a pre-war context where we had very high prevalence, heavy intensities, and a lot of polyparasitemia. This is really, really an impressive achievement. The high prevalence sites are still closely related to sites with the lowest access to clean water and improved sanitation. An NTD sustainability plan is working to maintain these achievements as MDA for LF and eventually MDA for onco phases out. The current gap for school-age children and women of reproductive age started to emerge in 2017 when the LF program started to phase out, and there is no MDA onco in the 2 districts around the capital, the western area, urban and rural. Next slide, please. So schistosomiasis was only prevalent moderately or highly endemic in the north and the east of the country. And in the 9 districts that were targeted with praziquantel, overall prevalence has halved, and moderate to heavy intensity infections are still running at around 10% in these endemic districts. We are anticipating another national survey to be repeated later this year. Next slide, please. So despite being one of the least developed countries in the world, we have managed to make remarkable progress when it comes to NTD and STH schisto control. One of the reasons is Sierra Leone is a small country, and in the dry season, you can, in a sturdy 4-wheel drive vehicle and a boat, reach almost every village in the country, although you wouldn't attempt to do this during the rainy season. There's been long-standing country-specific research interests into Sierra Leone, specifically pre-war in the 1990s. This was coming from Glasgow University and what was then the WHO Collaborating Centre for Ascariasis. Decentralized healthcare certainly helped district health management teams specifically strategize for their hard-to-reach communities. And postgraduate training in public health administration has also been a great success for healthcare leaders. We shouldn't underestimate the scope of the internet to be able to reach even hard to reach locations. In 2010, we had channeled a lot of information over the internet to target our urban communities, and much to our surprise and delight, found that we were reaching the most hard to reach communities in the rural locations that had not been reached by conventional community sensitization strategies over the previous 3 rounds. Communication channels, they have to be tailored and they have to be pre-tested and they have to evolve over time as community perceptions of risk, benefit, and of rumors change over time. In the local context, we translated our messages into 7 ethnic languages, but found to our surprise in 2020 that one language, Limba, had at least 5 distinct dialects, and we were missing a significant proportion of that ethnic group by only using 1 dialect. We've benefited from long-term investments from donors, and we've also learned that community engagement has to be a 2-way stream. It's no longer sufficient to just be pumping out information. People have the information, they have the knowledge, but they may not have the trust in some sectors of the health service, and you need to be responsive to their fears and the rumors that are circulating, especially during things like Ebola and of course recently COVID. We use electronic data for monitoring the performance of our implementers. And the most important lesson I think we've learned over the last 10 years certainly is the power of integration. Transitioning from mass campaigns for the preschoolers into an integrated service delivery that included family planning for their caregivers was a real success. And going forward, I would recommend that further integration channels for adolescents and women of reproductive age should take a careful look at the opportunities to provide long-acting contraception, especially hormonal implants and IUDs. Integration, I think, is the key to success going forward. Thank you.
Thank you very much, Mary. I am now going to thank all of our country representatives, and we will have questions towards the end of the webinar if there is time, but we will note the questions that have been already put into the chat. I would now like to invite our videographer to present our second video entitled Deworming Programs for Women of Reproductive Age, Highly Feasible and Low Cost. Please cue the Thank you very much. Thank you very much for that interlude. We will now continue with some statements of support from our partners. Antonio, will not be the presentation right now. First, we will invite Christopher Castle from UNESCO to provide a statement of support. Christopher.
Thank you very much, Chair. Just to briefly say what a pleasure it is for UNESCO to be invited to participate in this important process. In particular, UNESCO believes that there are a lot of important opportunities to consider education starting from an early age to promote awareness of the importance of deworming and its influence and impact on women of childbearing age in a sexual and reproductive health context, and also in particular through comprehensive sexuality education programs that UNESCO and other UN agencies support countries to implement and scale up. So just wanted to applaud this particular initiative and effort, and thank everyone for the opportunity for UNESCO to be involved. Thank you.
Thank you so much, Christopher. Jutta Neisel from the World Food Program, are you there? I'm not seeing if you are there.
So when we're in partnerships, it's also about trusting, because you could actually do 10 votes, but I'm only use 3.
I think that some microphone has been opened inadvertently. Perhaps we'll go then to Dr. Paul Emerson from Children Without Worms. Paul?
Yes, good morning, good afternoon, good evening, and for those in Peru, it's the middle of the night. I'm not even sure how to mention that one. Listen, thank you so much. What a great session this has been. I'm really happy to have been invited to participate. For those of you who don't know, Children Without Worms is a program of the Task Force for Global Health here in Atlanta in the United States. Children Without Worms, we're not only concerned about eliminating morbidity from worms in children, but also for women and girls. And we've heard today, there is a really disproportionate risk of morbidity experienced by that group compared to older boys and men. And this is just a super way of launching the focus back onto older girls and women of reproductive age. We're taking an active role with WHO and other partners to use community-based and other appropriate measurement tools to use the data where it exists, of course, help to generate it where it doesn't, to refine programming and direct the donated medicine to where the risk of morbidity is the greatest. We would like to see no one left behind. Children Without Worms, Task Force for Global Health, we're proud to be a partner in the policy brief on deworming. Thank you, Chair.
Thank you very much, Paul. Now on to Dr. Anouk Guvras from Global Schistosomiasis Alliance.
Hello, everyone. Really our heartfelt thanks to our colleagues at the World Health Organization for giving us the opportunity to express the Global Schistosomiasis Alliance support for this policy. We have seen great progress made in controlling schistosomiasis, but we know that there are some groups missed by treatment programs. For these groups, the disease can be particularly dangerous. As we have heard, women can suffer so much misery and pain from schistosomiasis, especially from female genital schistosomiasis. On top of the physical pain and discomfort this disease can cause, women with female genital schistosomiasis also have to contend with stigma and isolation. Female genital schistosomiasis can be life-threatening and life-altering, and the evidence is clear it is a dangerous condition for sexual and reproductive health in endemic areas. We know that regular deworming can prevent female genital schistosomiasis, and we must do whatever we can to stop schistosomiasis from damaging the lives of girls and women. At the GSA, we work with the schistosomiasis community by providing a platform for discussion and knowledge exchange. We have a growing community of practice on genital schistosomiasis. And we welcome new members to share experiences and support ideas on how to work together in the health and education sectors. As an alliance, we help improve treatment, diagnosis, education, and understanding of schistosomiasis. The Global Schistosomiasis really fully supports this policy. Together, we can eliminate schistosomiasis and soil-transmitted helminthiasis, and together we can beat NTDs. Thank you.
Thank you so much, Dr. Guvras. From the World Food Program, Jutta Neitzel. Please unmute your mic. Jutta, please unmute your mic.
Thank you for the hint, and apologies for being late at the earlier time assigned. So we all know that hungry and unhealthy children can't learn well and can't grow well. And I think the continuous research renews all our conviction that it's essential to invest in the health and nutrition during the entire childhood, during the entire 8,000 days. And we are also all well aware that there are different phases of growth, as also highlighted by the various speakers today. in our experience, we think that schools are a particularly effective platform, and I think that also came through from Peru and Cambodia, to reach children. Our particular expertise at WFP lies, of course, in school meals. We are working with governments in school meals since over 6 decades, also through the very difficult past 2 years, where in many countries schools were closed, and we try to find alternative solutions. I think I trust that the various colleagues of WFP who I noticed are on the call today all agree with me that since we started school meals, we try to improve and be more effective. We try to improve the meals, make them more diverse, more nutritious, more healthy, more local. So there's a great deal of effort coming from the international community into that. And we know that's all worthless if there are worm infections, because we all, of course, are not interested to feed the worms. So for us, this discussion you are having today is critical. We believe it's a critical investment to be made. It's cheap, it's easy to do. We did it together with WHO and UNICEF, our partners, providing the pills since many years very effectively. It's a critical school health intervention package. We're very happy that the discussion goes on, that the attention on it goes on. We're also very happy that you are now zooming in on the particular problems of adolescent girls. And what we very much hope that while the world is investing in school meal programs in the scale and the quality, that investment will be accompanied by efforts from everybody to also bring in deworming at the same time to the same children to have an effective package. So thank you very much for the discussion today. We are looking forward to work with you. Thank you
so much. Thank you so much, Jutta from World Food Program, and thank you to all the partners that presented their statements today. I would now like to invite Dr. Antonio Montresor to officially show us the policy brief and to make some conclusion about the minimum strategy that is being recommended. Thank you, Antonio. If you would, presentation mode. Yes, perfect.
Thank you very much, Teresa. I hope you hear me. So we are at the end of this presentation of launching of the policy paper for women of the woman reproductive age. So basically, based on country experience, WHO developed this minimum strategy to control the mobility for STH and schisto in adolescent girl reproductive age. And this minimum strategy is also, we try to make simple and very low cost. So we suggest not to do specific surveys for this age group, but whenever the worming with albendazole or mebendazole or praziquantel is provided to children, this medicine can also be administered to the girl and woman. They are living all in the same environment, so there is no reason why the children are infected and the woman not. So the area of distribution of this drug is exactly the same. And second characteristic of this minimum strategy is the use of existing infrastructure. So we can use HPV vaccination or iron folic acid supplementation campaign to reach the adolescents. We can use antenatal and postnatal clinic to reach pregnant women and lactating women. And we can use child vaccination service to reach the mother when they are bringing their children to their vaccination. So we publish this policy paper in 3 languages at the moment. We join forces with UNICEF, WFP, but also with UNESCO, with TIBA, with Children Without Worm, with the McGill University and London School. Basically, the policy paper is a leaflet. In this internal part, there are question and answer. We try to address the main question that can raise for manager of control activities when they have to start this kind of intervention. And then on the back, we have country experience and the link where to have more support, and also the summary of the minimum strategy. We are planning to send this policy paper to all the country offices of WHO, UNICEF, WFP, and UNESCO, and facilitating the engagement with ministries in order to better cover this group at risk. So finally, a nice news. Basically, we have WHO have a MOU, a memorandum of understanding with Johnson & Johnson. We renew this memorandum of understanding, and the focus of this donation of mebendazole is remain for preschool and school children. But we agree that if there is any balance remaining from the drug used in the preschool and school children, we can use this drug for woman reproductive age. So we expecting increasing number of pills to be available for women, because our coverage of school children and preschool children is going so well that we are seeing that less and less pills are needed in that age group. So we expect to have in the future more pills available for a woman reproductive age. How we will act? We will ask the country to request the drug also for this age group. And once we have satisfied the request for preschool and school children, then we will also start to respond to the request for woman reproductive age. And we hope to, in this way, to scale up the coverage. So this is all I wanted to say you. Thank you very much. And then I pass it back the mic to Teresa.
Thank you very much, Antonio. And I would like just to have a little bit of a balance with schistosomiasis and invite Dr. Garba, Amadou Garba, just to make a plug for the next schistosomiasis event. Are you there, Amadou?
Yes, thank you, Teresa. So I would like to inform the NTD community that we are going to launch the new schistosomiasis control and elimination guideline on 15 February. So I shared a link through the chat for people to register for this important event, which will provide with the new recommendation for implementation of control and also assessment of interruption of transmission of schistosomiasis. Thank you, Teresa.
Thank you. I'll put it in my agenda. Thank you very much. It's now a pleasure to close this webinar. I'd like to close by thanking all of the speakers and panelists who provided key insight into various aspects of this world of deworming for adolescent girls and women of reproductive age. To all the partners whose support is so much appreciated, to the translators who've extended our reach into Spanish and French audiences, and to all those behind the scenes who made this webinar happen. And to all of you who have registered for this event, I hope that you have found it informative, and I hope that your interest in deworming as a public health intervention will improve the health of adolescent girls and women of reproductive age, and it'll have an impact on the global agenda moving this goal forward. And hopefully we're all contributing to eliminating these NTDs by 2030. Thank you so much. Good morning, everyone. Good afternoon, good evening, and see you at the next webinar, perhaps on February 15th. Goodbye, everybody.
And Teresa,
Bye.
thank you very much to you also
Thank you.
for sharing this meeting. Thank you very much.
Thank you.